Good afternoon. Good afternoon to my fellow commissioners and welcome to those tuning into the live stream. I apologize for the delay. We had a technical difficulty. Thank you for your patience. I want to begin today's meeting with an important introduction. Since our last meeting, Commissioner Tim Foley has resigned as a member of the HPC board, and the state auditor, Diana DiZoglio, has appointed James Wilmoth to the HPC board to fill the seat of a member with demonstrated experience in representing the healthcare workforce as a leader in a labor organization. Before I introduce Jamie and we'll ask him to say a few words, I want to pause and thank Tim Foley for nearly 9 years of exemplary service to the HPC and the Commonwealth. We wish Tim well on his future endeavors, and on behalf of my fellow commissioners and the team at the HPC, our deepest thanks. James Wilmoth serves as Senior Policy Analyst for the Massachusetts Division of 1199 of the SEIU, and he leads policy creation and development related to healthcare reform. We're very happy to have Commissioner Wilmoth join the HPC board. The expertise that he brings is going to be an asset to our mission and work across all of the issues we consider, but especially with our work in the support of the Massachusetts healthcare workforce. So welcome to you, Commissioner Wilmoth, and could I ask you to share some introductory remarks?
Sure. Thank you very much. I appreciate that generous introduction. I really truly feel privileged to serve on this board, and I'm really looking forward to working with David, the incredible HPC staff, and my fellow commissioners to advance the important mission of this agency. As you all know, the members of 1199 and all frontline healthcare workers across the Commonwealth are directly involved with and significantly impacted by healthcare policy in a myriad of ways. They obviously care very deeply about provider funding, workforce development, licensing standards, and other policies that directly impact their wages, benefits, and working conditions. And of course, they're severely challenged by staffing shortages that we face across the marketplace. But healthcare workers are also healthcare consumers. Accordingly, they're also fundamentally concerned about healthcare costs, about advancing health equity, and about ensuring affordable access to healthcare services for themselves, their families, and their communities. The healthcare workers stand ready to help develop and implement policy reforms to better monitor and hold accountable all the actors in the healthcare marketplace. And they simply want a voice in the HPC's efforts to control costs, better regulate the market, including private equity entities, and to revitalize state health planning. I really thank you for this opportunity. I'm here to amplify the voice of the Massachusetts healthcare workforce and to hopefully play a small role in advancing a broad range of reforms on their behalf. So thanks again for the introduction, and I really look forward to the work.
Thank you so much. So do we. Thank you for serving. So we'll now move to introduce our agenda for today. We're going to begin today's meeting with a review of the final report on the cost and market impact of the Dana-Farber Cancer Institute, Beth Israel Deaconess Medical Center, and Harvard Medical Faculty physicians at BIDMC. And the commissioners will consider a vote to release our final report publicly. We'll then move to reviewing data and testimony from the healthcare cost growth benchmark hearing, which we held on March 13th at the Massachusetts State House before we set the healthcare cost growth benchmark for calendar year 2026. And we'll take a vote on that. Then our staff the HPC staff will provide an overview on several issues. First, the accountable care organizations, learning, equity, and patient-centeredness certification standards, highlights from the newly released OPP annual report, and agency updates in the executive director report. Then before we conclude, we'll ask for a vote to move forward with renewal of the HPC's executive director's employment contract. Our first order of business is to consider and vote on the minutes from our last board meeting on February 27th. And I'll turn to Colleen Elstermeyer to walk us through that vote.
Absolutely. So if there are no amendments to the minutes from February 27th, I'll ask for a motion.
So moved.
And
Motion.
and a second, please.
Second.
Thank you. And with a roll call vote, I'll ask for you first, Chair DeVoe.
Aye.
Vice Chair Cohen,
Aye.
Commissioner Castiel.
Aye.
Commissioner Coughlin,
Aye.
Commissioner Cutler,
Aye.
and Commissioner Haupt will ask you to abstain.
Abstain.
Thank you. Moving to Commissioner Master Giovanni,
Aye.
Commissioner Sullivan. Thank you. Undersecretary Mahania
Abstain.
and Commissioner Wilmuth abstain as well.
Abstain.
Thank you so much. Back to you, Madam Chair.
Thank you. Thank you so much. And I'll now turn to David Seltz to introduce our agenda item on the cost and market impact review for the Dana-Farber BI project.
Good afternoon, commissioners. Thank you, Madam Chair. Good afternoon to all of you who are watching on our web stream for this important meeting. We have a number of important topics to discuss and deliberate on today. First, beginning with our final report on the cost and market impact review of the new relationship between Dana-Farber, Beth Israel Deaconess Medical Center, and Harvard Medical Faculty Physicians. Commissioners, as you know, this has been a extensive process of review for this particular transaction, reflective of how important this transaction is and the significant change it represents to oncology care in Eastern Massachusetts, and a new relationship between two prestigious organizations. Throughout this process of developing these cost and market impact review reports, our goal is really to bring transparency to the public, to policymakers, and to other market participants about what our analysis can show in terms of potential impacts in a number of domains, including cost and market impacts, quality and access impacts, and equity impacts that may arise from a given significant market change. As with all of our cost and market impact reports, it is not our authority to approve or deny, but really to provide important information, as I said, to the public and to other state agencies. Our goals really are to maximize the positive potential of any such market change, and of course, minimize the potential for any negative changes. Before I turn it over to Sasha to walk through our final report, including our analysis of some new information that was submitted to us from Dana-Farber, I do want to just take a moment and pause and reflect our appreciation to the parties under review for their cooperation and professionalism throughout this entire review process. This has been, a new and complicated area of inquiry specific to an important service line in oncology, and their willingness to provide input and to help us understand and appreciate the nuances specific to the delivery of high quality oncology care. That was really essential for us to be able to produce this robust report. In that same vein, I also appreciate the input of other market participants who we have called on throughout this process to help ensure that we're properly contextualizing this important change. And this is a significant change, and it is happening in the context of larger changes to oncology services across Eastern Massachusetts. So we do hope that this final report provides important information to all of those parties and to help us understand what potential impacts may be, how we might mitigate them, understanding that this transaction and the construction of the new cancer hospital will be taking place over a number of years in an environment of some degree of extreme uncertainty. So with that, I am happy to turn it over to our staff to walk through, as I said, our report, our findings, and to answer any questions you may have.
Thank you, David. And thank you, commissioners. I want to take a moment and reflect again, David's thanks to the parties for their cooperation over the course of the review. I also want to thank the team that led this review. We didn't have time to shout them out last time, and I want to specifically thank Rebecca Balder, Josh Roth, Alexa Paiva, Sydney Birnbaum, and Jessica Liu, along with many others on the team and across the agency who supported this work. I want to start by briefly recapping. This CMIR examined the proposed clinical affiliation between Dana-Farber, BIDMIC, and HMFP. Under the affiliation, Dana-Farber would become the preferred provider of medical oncology services for BIDMIC and HMFP. BIDMIC would discontinue medical oncology services at its main campus, and the HMFP medical oncologists there would become Dana-Farber employees. The party's expectation is that BIDMIC and HMFP medical oncology patients would transition to Dana-Farber. BIDMIC and HMFP in turn would become DFCI's preferred clinical partner for surgical oncology services, replacing Dana-Farber's current clinical partner, Brigham and Women's Hospital. And the parties would coordinate to provide related services, including forming a joint venture to deliver radiation therapy. This new relationship would be anchored by the proposed construction of a new cancer hospital for Dana-Farber on land owned by BILH. The hospital would have 300 inpatient beds, new observation beds, and expanded imaging and radiation therapy units. The party's expectation is that the new hospital would serve current DFCI patients, current BIDMIC patients, and patients currently receiving oncology services in beds at Brigham who have DFCI medical oncologist attendings. On the next slide, after an extensive review and analysis of information provided by the parties, other market participants, as well as available data on measures of cancer care costs, prices, quality, and access in Massachusetts, the HPC published its preliminary CMIR report at the end of February. As you'll recall, we found that the proposed affiliation is likely to result in substantial shifts in where patients in the Commonwealth receive oncology care. Because of differences in hospital prices and commercial plans for the same care, those shifts of patients would result in changes in spending. Shifts in inpatients from BIDMIC, Brigham, and other hospitals to the new DFCI facility would likely reduce annual commercial spending by $18.5 to $23 million. As BIDMIC backfills capacity of patients who would shift to DFCI, there would likely be additional commercial savings of $3.5 to $5.3 million a year. Backfill at Brigham would likely increase commercial spending by $4.2 to $15.9 million a year as a result of Brigham's high relative commercial prices. On the outpatient side, shifting care to Dana-Farber would likely increase commercial spending, with most of that increase due to higher DFCI prices for oncology drugs and related services as compared to BIDMIC. Shifts of Medicare spending would produce similar results, with inpatient shifts to Dana-Farber saving $5.7 to $9.1 million at current prices, but with outpatient shifts to Dana-Farber potentially increasing Medicare spending. We noted also that because Dana-Farber's Medicare reimbursement is based in part on its cost of care, increases in Dana-Farber's costs in the new facility could reduce savings or result in increased spending. Similarly, on the commercial side, significant increases in Dana-Farber's commercial prices would reduce savings for inpatient services or further increase spending for outpatient services. And we invited the parties to respond to these findings, including an invitation to provide commitments regarding the potential for the transaction to result in higher future price increases and regarding Dana-Farber's already high outpatient rates. On the next slide, regarding clinical quality, the parties are high-quality cancer care institutions, and the HPC didn't identify concerns regarding changes in the quality of care as a result of the transaction. We did highlight the potential for the proposed shifts in care affiliations to potentially result in short-term disruptions and the need for the parties and other oncology providers to develop robust plans for care coordination to try to limit any of those potential disruptions. Regarding access to care, we reviewed factors likely to impact inpatient oncology utilization and ultimately found that it's unclear whether the party's specific proposal is necessary or sufficient to meet future access needs based on currently available information. We found that the parties have begun planning to collaborate and expand on their existing access and equity initiatives, and we highlighted the continued attention to and investment in those collaborations, as well as attention to delivery of cancer care in community settings, are going to determine the extent to which this affiliation results ultimately in more equitable access to cancer care for underserved populations. Next slide, please. As you'll recall, in addition to the HPC CMIR, the Department of Public Health has been conducting a review as well, focused on the construction of Dana-Farber's new hospital. The Determination of Need program evaluates DON applications on its own set of factors, including projects' competition on the basis of measures of healthcare spending and the contribution of projects to the Commonwealth's cost containment goals. After the release of the HPC's preliminary report, DON staff recommended approval of the DFCI hospital project with conditions, and the Public Health Council approved that recommendation by a vote on March 20th. By law, that DON approval does not go into effect until 30 days after the HPC completes its CMIR by publishing our final report, and DPH may rescind or amend an approved notice of DON on the basis of findings in the CMIR, as noted in that notice of approval. Next slide, please. The conditions of approval that were put in place by DON include the standard contribution to the state's community health initiatives, as well as a slate of annual reporting measures for 5 years on a set of access, equity, and quality measures. In addition, on the next slide, if during the pendency of the DON, DPH identifies that Dana-Farber's mass health payer mix materially declines, Dana-Farber can be called on to develop and implement an action plan to boost its mass health mix. And DPH also required Dana-Farber to report information on its case mix adjusted revenue per discharge, essentially a risk-adjusted measure of average inpatient pricing across all payers. And if the DON program identifies increases in those revenues that it considers substantial, it can require DFCI to explain the reasons for those increases. And if those increases in revenue per discharge on a case mix adjusted basis is higher than the benchmark for that year, Dana-Farber has to explain the growth to DPH. And if the Public Health Council determines that the increase was not due to innovative treatments or forces beyond Dana-Farber's control, it can require DFCI to make additional investments into DFCI's health equity programs. On the next slide, the next development that occurred chronologically is that the parties have an opportunity to respond to the HPC's preliminary report. Dana-Farber provided a response, BIDMIC and HMFP did not. Dana-Farber's response included statements that DFCI is committed to providing cost-effective cancer care, but argued that cost containment in oncology and even accurately assessing price differentials in oncology is difficult. Dana-Farber's core argument has been that the HPC's estimates of outpatient spending increases don't account for Dana-Farber's unique patient population and services. Dana-Farber also stated it's committed to working with community partners as well as with BIDMIC, MGB, and the state to ensure a smooth transition of care. Dana-Farber offered some arguments that the HPC should have used different assumptions about shifts of care, and that we underestimated savings from shifts of inpatient surgical care from Brigham to BIDMIC. And Dana-Farber asserted that other oncology providers in the Commonwealth would be minimally impacted by the construction of the new hospital, because if it were to open tomorrow, it would be filled if it were filled by all of Dana-Farber's, BIDMIC's, and Brigham's oncology patients. On the next slide, I'm going to turn it over to Lois to review some additional discussion between the HPC and DFCI.
Thank you, Sasha. And we did reach out to Dana-Farber for discussion of potential additional commitments to build on the conditions included in the DON approval. And we're pleased that they did make 3 specific commitments to the HPC. First, Dana-Farber agreed that it would confidentially report to the HPC on its price increases, not just for inpatient, but including outpatient price increases as well for commercial payers Medicare, and Mass Health for the 5 years after the hospital is operational. Second, as they committed to work with us to understand the total cost of care for oncology patients, Dana-Farber also committed to provide confidential information specifically around outpatient oncology drugs and their pricing, so that to allow the HPC to understand how that pricing is developed and to monitor the pricing used by other market participants. Finally, Dana-Farber committed to publicly report on its efforts to provide cancer care in the community, also for the 5 years following the operation of the hospital, with specific metrics around the number of community hospital patients Dana-Farber's providers will round on at community providers, the number of patients treated at community sites that don't have an inpatient admission at the Dana-Farber main campus, and the number of consultations provided in community settings. And those are reflected in the final CMI report. Turning it back.
On the next slide, to review Dana-Farber's comments on the preliminary report, we assessed the response in detail. Fundamentally, the information provided by Dana-Farber in the response doesn't change the HPC's assessment that Dana-Farber receives substantially higher commercial outpatient prices, and that is likely to drive a significant spending increase as BIDMIC oncology patients switch to receiving their outpatient care from Dana-Farber in the future. Of the commercial spending impacts for outpatient services that we quantified, $31.7 million roughly is based on just a repricing of oncology drugs, infusion services, and evaluation and management services, taking those same services used by BIDMIC and HMFP patients that the parties expect to transition to Dana-Farber and repricing them at Dana-Farber's prices. On the potential for rate increases, the DON condition and DFCI's commitments to report confidentially on its prices to the HPC will allow us to assess to what extent the transaction impacts Dana-Farber's future price growth. However, the potential for reduced savings or increased spending remains if Dana-Farber's prices increase relative to other providers, and Dana-Farber hasn't committed to directly limiting those rate increases. We welcome Dana-Farber's affirmations, of course, of its commitments to efforts to improve equitable access to care continuity, patient satisfaction, and clinical quality. And we look forward to the parties' continued attention to and reporting on those efforts. And finally, we recognize that the parties have different assumptions about the extent to which Dana-Farber will be able to pull patients from Brigham. The information in Dana-Farber's response doesn't change the HPC's assessment of which Massachusetts patients will most likely fill that new inpatient capacity that's been proposed. Similarly, potential impacts on other oncology providers and the impact of the proposed transaction on the accessibility of inpatient care remain fundamentally unchanged. On the next slide, I'll say Dana-Farber's responses appended to the final report. We've written up a full assessment of their response and attached that as well. We've made some additional minor changes in the final report as well, some of which are noted here. They're largely to provide clarity or provide additional context in the report. One substantive change that I'll note here, though, is that we were able to expand our analysis of outpatient surgical procedures that might shift from Brigham to BIDMIC as a result of the transaction, including some additional procedure codes related to cancer. That resulted in a higher estimate of commercial savings on outpatient surgery that might shift to BIDMIC, that estimate rising to $6 million of commercial savings annually. And the final report and the following slides reflect that new higher figure. On the next slide, though, all in all, fundamentally, the core findings of our review remain unchanged. We identify a likely net savings on inpatient care as inpatients shift to Dana-Farber's new hospital and BIDMIC and Brigham backfill that volume. However, we find a potential for a net spending increase on outpatient care, primarily driven by BIDMIC and HMFP patients receiving outpatient care at Dana-Farber's higher prices. The ultimate spending impacts will depend on whether Dana-Farber maintains its low relative prices for inpatient care and reduces its high relative prices for outpatient care. Dana-Farber hasn't committed to directly limit rate increases or address those high outpatient prices, but its commitments to the DON program and to the HPC will allow the Commonwealth to assess the extent to which the transaction impacts Dana-Farber's price growth for a period of time following the construction. In the quality and access spaces, the HPC's findings have not changed, although we welcome Dana-Farber's affirmations and commitments around continuity of care planning, collaboration with other provider organizations to deliver care in settings outside of Boston, and continued attention to and investment in those efforts by all of the parties will ultimately dictate the extent to which the transaction impacts clinical quality and equitable access to cancer care. Next slide. Based on our next slide again, please. Based on our findings, we recommend the board vote today to release the final report and submit it to DPH with a recommendation that the commissioner assess the need for additional or revised conditions to the approved DON. We also recommend submission to the Attorney General to consider in the context of her ongoing monitoring of the Massachusetts healthcare market, including other changes that are currently occurring in the oncology care space. And on the next slide, I'll note that the publication of this final report is the last step of our CMIR process and will formally conclude our work. By law, the parties can't close their transaction until at least 30 days after the publication of the final report. You'll recall that this period was specifically built to ensure other state regulators have an opportunity to consider our findings and take any additional necessary steps. With that, I'll pause for any additional questions or otherwise turn it over to Colleen and the chair for a vote.
Any questions, comments?
Okay, let me just make a few comments before we turn to the vote. Can we show the whole screen just so that I don't miss any commissioner that's also trying to speak? So what I just want to recap is that, as the team is pointing out, what we're focused on in the final report is that the ending of the relationship between Dana-Farber and the Brigham means that over the next 5 years, cancer care is going to change in many ways, including the specific reporting that we're doing today. But each of the organizations involved, both Dana-Farber and the MGB, are going to build new facilities, new capabilities that have significant implications for cost and access. So in our final recommendations that the commissioners will vote on in a moment, what we're recognizing is that although extensive work has been done by us and others, other government agencies in this process, to evaluate the plan based on what we know today and what we can project reliably, we fully appreciate that all of these assumptions and projections are going to evolve significantly over the next 5 years as patient care changes, the cost of access to these medications may change, the needs change, the level of cancer care needed changes. And so the critical need that we're focused on in our recommendations is monitoring what actually happens, and that agreement with Dana-Farber to do that, but also the need to look at the entire cancer care market. And so our submission of the report to the AG's office is in line with their market review function, where, as we know, they each year do a market review, and that we believe that all of the agencies involved, including us, will want to work with the entities in the market to evaluate, understand, and monitor what actually happens. And that is going to be in the great interest of the, of consumers and of our Commonwealth to understand what happens with cost and access. And of course, quality, although as our team and others have pointed out, we do not, take this vote with existing or really future concerns about the integrity and quality of the services. Our concerns are really more about cost and access, although of course we'll look at the quality as well. So any questions about what we're recommending either to DPH or to the AGO? Commissioner Cutler?
Thanks, Deb. My thoughts actually ran along the same line of yours, which is that the most important thing the Commonwealth doesn't have here is a good state health planning process, or at least an understanding of likely medical needs. And so, so a lot of what's happening here is sort of transferring inpatients from one institution to another, and that's great. And, it has some cost savings and some cost increases and so on, and we lay those out. And then, of course, fundamentally, there will then be feedback effects in terms of we'll then get other cancer institutions and so on. And what was then missing was a way to evaluate, well, I don't know, how big a capacity in oncology services do we need in the Boston area, and what will happen to other providers, and what will happen to providers in other parts of the state, and so on. And so that was the missing piece. What turned out to be hard in my mind was not the impacts of this, but the broader impacts of the change. And I think that's something we've had difficulty with because the state has not had that kind of planning process. Now that we do finally have authorization to do that, I hope that we'll be able to do that so that then when we evaluate this and other proposed transactions, we'll be in a position to say, well, actually, we kind of know that we do have that capacity now. So, maybe this makes sense, maybe it doesn't, but we ought to think about this market as a whole rather than just a sort of each one as a kind of one-off capacity change, because together they add up to quite a lot.
Yeah. Very well said. I think it's taking this in the broader context and understanding the broader context of cancer care is what's ahead. And our role in that will be very important, as you point out. Commissioner Wilmoth?
Thank you. I wanted to say something similar, which, SEIU we formed a 10 taxpayer group and have made extensive comments to the DPH around this project. Our concerns has always been twofold. One is sort of the impact on safety net hospitals in the Metro Boston area and their capacity and their ability to, serve cancer patients. But most importantly about the workforce and Dana-Farber's response here, provide some additional details about their plans to staff up, but they need 2,500 new workers. They seem to have a pretty good plan for a pipeline for doctors and nurses, and they mentioned in their response that a lot of these future workers are currently in high school or college, but they're going to need administrative staff, radiation oncology, imaging, lab services, a range of workers here who are not just doctors and nurses. And we're already, as everyone knows, there's already a massive staffing shortage in most of these areas. So, we will continue to push Dana-Farber to, give us do a little more planning around that, really focus on the incumbent workforce that exists. We've been doing a lot of work with our training fund to train incumbent workers, train them up, not only to become nurses, but to become pro-techs and lab specialists and the like. So I think there's a little more work to do there. And, I appreciate Dana-Farber's optimism, but we are concerned that this is a significant new workforce that doesn't seem to exist today. And that, it's going to require quite a bit of workforce development and training work to get there. So just wanted to make those comments, even as, happy to support this report today.
Thank you. Thank you so much. Other comments? Questions? Any questions about the additional commitments that Dana-Farber has made since the preliminary report? Okay. Well, thank you. Thank you to the team for both the work on this and also for the ability to work with Dana-Farber to make the additional commitments in response to some of the issues that we raised. So let's now move to a vote, which would approve the release of this final report. And Colleen Ostermeyer, if I can turn to you to handle the vote on this.
Absolutely. I'm asking for a motion
So moved.
and calling for a second.
Second.
And by roll call, starting with you, Madam Chair,
Aye.
Vice Chair Cohen,
Aye.
Commissioner Castiel. We have an aye. Commissioner Coughlin,
Aye.
Commissioner Cutler,
Aye.
Commissioner Haupt,
Aye.
Commissioner Master Giovanni,
Aye.
Commissioner Wilmuth,
Aye.
Commissioner Sullivan,
Aye.
and Undersecretary Mahania.
Aye.
Thank you.
Terrific. Thank you so much, commissioners, and thank you to the HPC team and to Dana-Farber, BI, and HMFP for your collaboration and work on this effort. We will now move to our next topic, which is to consider and vote on the healthcare cost growth benchmark for calendar year 2026. Let me turn this to our Executive Director, David Seltz.
Thank you, Madam Chair, and thank you, commissioners, for the vote to issue that final report. I do also want to recognize the additional commitments made by Dana-Farber to provide information that, as this transaction moves forward, will really help us in that ongoing monitoring. And just picking up on something that Professor Cutler said, appreciate that some of the new responsibilities in the legislation, specifically the establishment of the Office of Pharmaceutical Policy and Analysis and the Office of Health Resource Planning, I think will have a tremendous beneficial role in helping us think through all of these changes and future changes in this space. And so look forward to the continued partnership and work on that. Shifting gears to this agenda item, we are now in the part of our annual process where we are here today to determine and vote on the healthcare cost growth benchmark for calendar year 2026. So growth between this year and next year. As you can see on this timeline, this annual process really begins at the beginning of the year when the House Committee on Ways and Means, the Senate Committee on Ways and Means, and the Executive Office of Administration and Finance meet to review economic projections and forecasts from a range of vendors and internal sources, and determine the annual growth rate of what we call potential gross state product, or PGSP, which is the long run growth rate of the state's economy. Those three committees and executive office met earlier this year and agreed that the potential gross state product would remain at 3.6%. So as we consider today, our process lays out that the default benchmark rate is at the PGSP level, or 3.6%. Unless there is a supermajority vote of the board to modify the benchmark either higher or lower. If the board elects to do that today, that does trigger additional hearings and potential review by the legislature if there is a modification. Next slide. So I presented this slide at the benchmark hearing and always feel like it's an important reminder about what is the benchmark and what it is not. Really, the benchmark is a measurable goal to help catalyze our collective action to improve healthcare affordability and access. We know that healthcare affordability challenges are access challenges. And so this benchmark provides that transparency about our performance of the healthcare system so that we can work together to improve those critical functions that are core values of the Commonwealth and the healthcare market. What benchmark is not is a strict cap. It is not a punitive measure. And it is really focused on healthcare expenditures as opposed to the internal administrative costs of organizations. And I mention that because as we observed in the Mass General Brigham's Performance Improvement Plan, some of their initiatives that were around reducing expenditure growth were really around enhancing the quality of care and bringing in more staff to be able to provide better care management for patients and reduce unnecessary utilization of the emergency department or readmissions. So it really is around how can we improve the efficiency and value of the delivery of healthcare. And the HPC has made many recommendations to that over the years. Next slide. Just to focus on the right-hand side of this slide, as part of our annual review process, we held that public hearing just a few weeks ago, and we looked and presented to you and to the public on a broad range of healthcare trends. We heard a presentation from the Center for Health Information Analysis, as well as from our own internal staff who brought together a number of different important metrics for consideration as we set this healthcare cost growth benchmark. And the next slide is a few reflections of some of that data that we did show at the benchmark hearing. Here, arraying the growth of family premiums, employee contributions, and employer contributions in the commercial market as compared to the growth in, for example, per capita GDP, median household income, and CPI, and arraying those differences. On the next slide, again, this was information we shared at the benchmark hearing, providing additional metrics for context of, on the right-hand side, healthcare spending and premium growth, in the middle, labor costs and overall CPI, and on the right, growth in median household income, and the 40th percentile household income, recognizing that income gains have not been achieved equally across different income groups across the Commonwealth. And in fact, income inequality has worsened in Massachusetts in recent years. Next slide. So again, just as context for why the benchmark is important and important to continue to set goals for improvement, this slide really was a reflection of a future state, here shown in blue, of the take-home pay with a 3.6% premium growth over the next 6 years, as compared to, in the orange line, a trajectory if premiums continue to grow at 7%. And we can see the delta in terms of what this means in terms of take-home pay for the residents of the Commonwealth, who are, like businesses and the healthcare organizations, also struggling with inflation and uncertain economic environments. Next slide. Finally, I also always want to mention that while the benchmark is this, kind of bright line statewide target, when the Health Policy Commission considers whether to require a performance improvement plan of any entity referred to the HPC, as you know, commissioners, we conduct a very comprehensive and extensive review to consider whether a performance improvement plan is warranted, including looking at things like population served, financial condition and cost structure, and factors that may be outside of the entity's control. All of these weigh into the HPC's decision about whether to require a performance improvement plan and provide important comprehensive context with information often provided by the entity under review that is as current and relevant as they can provide. Next slide. I mentioned this at the hearing, but also just wanted to again highlight that we are not alone in this effort to set measurable goals for healthcare cost growth. There are, shown in the dark blue or dark orange, I should say, a number of states that have also established statewide healthcare cost growth targets or benchmarks. And I would note for the board's information that many of our sister states have set their benchmark targets for 2026. And in many cases, those targets are either consistent or lower than our current default rate of 3.6. Oregon has a 3% target for 2026, Washington 2.8, California 3.5, and Connecticut 4%. Next slide. I'll turn it over now to our General Counsel, Lois Johnson, to provide a brief summary of all of the testimony that we received as part of our public hearing last month.
Thank you, David. And the HPC did receive testimony both at the hearing and in written submissions from a broad range of organizations representing different vantage points across healthcare providers, purchasers, and consumers of healthcare. And to recap, as shown here, those organizations who did recommend a specific growth rate for the board to set the benchmark for the coming year testified in favor of maintaining the benchmark at the current default rate of 3.6%. Two representatives of business and employer groups actually advocated for lower than 3.6% or 3.1%, emphasizing the importance of maintaining a spending target that balances sustainable growth with affordability. Associations representing providers, specifically hospitals and physicians, did not specify a benchmark rate, but rather recommended either suspending the benchmark in the coming year or reforming the benchmark framework, or both, saying that the framework doesn't account for current economic circumstances, and with some critiquing the use of potential state gross product as a metric. Other testimony we received recommended specific reforms unrelated to the benchmark, including potential change in scope of practice laws, a reform to the small group insurance market, or behavioral health service reimbursements. Next slide, please. So this slide shows the themes that really dominated the testimony we received and provided context for the recommendations of the witnesses. Testimony underscored affordability challenges faced by patients and businesses across Massachusetts. We heard that small businesses are facing ever-increasing premiums. We heard that patients are facing ever higher deductibles and cost sharing. And insurers raise concerns about the pressures of pharmaceutical spending growth, which raising that it lacks oversight in our framework, and the need for help to address affordability. Witnesses also testified about that those affordability challenges that they raised have significant implications for health equity and access across the Commonwealth. For their part, healthcare providers emphasized ongoing capacity and workforce challenges in the wake of the pandemic that impact their ability to make meaningful changes to lower spending. Their testimony highlighted challenges in recruitment and retention of a diverse workforce, addressing provider burnout, and managing capacity constraints across the spectrum. Testimony also emphasized the need for maintaining an accessible, high-quality primary care system to address capacity bottlenecks and ultimately lower the cost of care. Witnesses expressed a new caution, the uncertainty regarding the future of federal funding and federal policy changes, which is a potential threat to ongoing work to address cost growth and affordability challenges. Next slide. Those same themes are exemplified here in these selected quotes that we're displaying. Again, pharmaceutical spending, administrative burdens on physicians, workforce shortages, and affordability of premiums and cost sharing.
Next slide. And before I turn it back to you, Chair DeVoe, to help lead the discussion of the board members, I just wanted to highlight that many of the themes and challenges that Lois just laid out in terms of dominant themes from the submitted testimony are also reflected in this new legislation that the legislature and the governor signed, the legislature passed and the governor signed earlier this year, that really provide the state and HPC in particular with new tools to be able to make improvements on many of those areas and to address some of those challenges and challenging headwinds that we see in healthcare spending. And so on the next slide, just to highlight how important we think that the urgent and robust implementation of those new laws is to continue to be able to work towards the healthcare cost growth benchmark. These little bubbles here reflect some of the areas that are going to be top of mind for the HPC's work this year. Highlighting a few on healthcare workforce challenges. We are currently working and have just launched a new primary care task force in partnership with the Executive Office of Health and Human Services that is going to be tackling some of the very specific issues that were raised about building a robust primary care foundation for our healthcare system and supporting our primary care workforce. At the same time, we are also excited that late last year, we launched a new behavioral health workforce center within the Health Policy Commission. That new center is well underway on its work to be able to identify and help address specific workforce challenges in the behavioral health space. Just below that, as we know, pharmaceutical spending has been one of the major drivers of healthcare costs and healthcare spending growth over the last few years. And this new legislation empowers the HPC to have a more dedicated focus on the pharmaceutical market and spending trends, and to be able to make data-driven and evidence-based policy recommendations that may be able to help drive value and efficiency in this particular market. And then finally, I'll just mention on the right-hand side, which was already mentioned, the Office of State Health Planning or Health Resource Planning, which is also new to the HPC, will be an important function for us to continue to build out this year as we think about the overall sustainability and balance of our healthcare system, and that it is meeting the needs of patients in all communities. So with that as an overview of both the benchmark process, the testimony received, and some of the areas of focus that HPC will be working on to help address some of those challenges and headwinds. Happy to take any questions, but also happy to turn it over to you, Chair, to help facilitate the discussion.
Thank you, David. And can we switch the slide format to show all commissioners? Thank you. So thoughts and questions from commissioners on the issues related to setting the benchmark for this year? And the legislation that's certainly giving us, an important new way to work on the costs over the coming year. So we feel the weight of that responsibility seriously and are looking forward to it. Any comments? Seeing none, can we?
David,
Madam
David
Chair,
Cutler.
we have, Commissioner Cutler.
I apologize.
No
Commissioner.
worries.
Please.
So I'm totally in favor of this. I think, given how hectic the last few years have been, what will be more important than the specific number is being sure that we will use every tool in the toolbox to help meet it. And I think because of the pandemic, it was difficult to be very strict about a number of things. And providers were in very bad shape and so on. And I think now that we've come out of that, we need to reaffirm that that is important. So that means obviously setting realistic numbers, but also making sure that we do everything that we can, including using the new authorities to make sure that that is met. And I think that's probably more important than the specific numbers, being very, very clear that that is a target and there are consequences that will follow if that's not met.
Yeah, good point. And there are differences in performance that we're seeing as providers are grappling with cost and emerging from the challenges of those years, as you referenced. Commissioner Castillo?
Madam Chair, I just would like to say that I'm extremely concerned about the cost of healthcare, and most importantly, that it's affecting communities of color who can't even afford insurance. My gut is to go lower. I understand where we are, but I want to keep that in mind that people are suffering because of this issue. Thank you.
Understand. And again, we heard at the hearing this year about the high levels of patients that are not getting necessary care because of the cost, which really underscores the point that you're making, Commissioner Castillo. Commissioner Cohen?
Yes, I think Dr. Castile put it exactly where my thoughts are. We have an affordability problem in healthcare, and the slides that David just put up show that dramatically. And while I would love to advocate for a lower benchmark, I think given where we are in our healthcare system today and some of the uncertainty we're seeing, both in terms of federal policy and workforce and so many other dimensions, I think maintaining the 3.6% benchmark is the route we should take.
Understood. It's a tough balance given the pressures that we're describing for consumers, but I understand your view. Commissioner Coughlin?
Yes, I also agree with maintaining the 3.6. I would like to say, we're at this unique time where we, as Commissioner Castile said, we're seeing a number of patients across the Commonwealth who are not receiving health care because of, the inability to afford it, but also because of, we have seen in the last couple of years a loss of services and beds. While at the same time, we're also seeing Massachusetts hospitals like expanding and new growth. So I think it's very important for us to be able to monitor those situations and to be able to take a look at, if we see a continued trend related to the ability of our patients to receive the care that they need where they need it. So I continue to believe that it possibly should be lower, but I'm okay with staying at the 3.6.
Yeah, you're really underscoring the need for the market planning and understanding how and where services are provided.
Exactly.
Yeah, thank you. Commissioner Wilma?
Thank you. I'm going to be supporting a 3.6 when we get to the vote. But I did want to say that I am somewhat sympathetic with the hospital, our hospital employers in my case, and then the hospitals and physicians in general who, express concerns about how the benchmark has impacted them, particularly safety net hospitals, and particularly in a situation where the majority of their spending is on labor, and workforce shortages both cost money in the short term and cost money in the long term to solve. I'm sympathetic to their proposals to look more closely at the benchmark over the next year or so, and think about ways that we can reform it. I know that the HPC has offered reforms to the benchmark process, for many years running now. But I think we need to take another look at those, another look at the, the proposal to maybe move to a multi-year benchmark while maintaining what I think David has pointed out has been a very important annual assessment, evaluation, and accountability process. but with the variation we've seen over the recent years, I'm sympathetic to the idea that maybe we should be looking at this over a 3, 4, 5 year time period. And that might give us more accurate understanding of the trends. So I just want to mention that as we go forward, I think, it's important. It'll be important for this board and for the HPC staff to really look closely at where we are with the benchmark, whether it's serving the purposes we need. I completely understand that the PIP process is misunderstood, and the enforcement of the benchmark is not really what the main issue we have here. But I do think there's an important opportunity and a really an obligation to respond to the physicians and the hospitals and these other major marketplace participants who are saying this benchmark is not working for us, and who have failed to meet that benchmark for a couple of years running now.
Thank you. Commissioner Mastrogiovanni?
I also support the 3.6, but at the same time, I think we should expect increases well above the 3.6 this year. And what's important is for the commission, which we have done in the past, and the team has done, you got to really analyze each of the factors that generate those increases to really address that and look at the organizations that may have exceeded reality in terms of where they should be. And that's what we need to focus on. So the 3.6 is fine, but let's face it, every year, we don't know what may happen 3 or 4 months from now, right? And we have to be on top of the individual factors that cause those increases.
Good point. That's where those comments that David Seltz was making earlier about our ability to consider the context and your amplification of that is really important, that we can look at those different factors and why an entity might be exceeding the benchmark, and if those are circumstances that
Exactly. Yep.
Great. Other comments or thoughts? I mean, what I'm hearing loud and clear is that while there's a general, I think, view that the 3.6 may be a reasonable place to land, there are strong reasons, and it's important to have the voice of Dr. Castile and also the voice of Commissioner Wilmoth around the factors that would cause us to want to lower the benchmark, which are very, patient focused, as Dr. Castile has articulated, and the deep understanding of the challenges to providers in achieving, if we hold the line on the existing benchmark of 3.6, achieving that, as Commissioner Wilmoth and others have acknowledged. Other thoughts or comments before we move to a vote?
Chair DeVoe, if I could just offer a thought. I really appreciate all of the comments here, and Commissioner Wilmoth, I think to your comments, I think one of the hallmarks of the way the HPC has done its work over the last 12 years is to be self-reflective and to evolve our approach and our thinking to meet the current challenges and dynamics in our healthcare system, which are constantly evolving, very difficult to predict. But we also need to be nimble and flexible as we consider our role in helping to balance those that are paying for healthcare, often at a very unaffordable rate, and those that are providing healthcare and the unique challenges that they provide. So, I do think, as you've mentioned, we have made recommendations in the past. I am, open and wanting to continue to have conversations with all of the interested stakeholders about what metrics and approach is most appropriate. And I look forward to doing that work this year with the stakeholders and with the board to see if there are additional recommendations and changes we might want to consider either legislatively or in how we set the benchmark each year. So open to that consideration as always. How can we evolve and meet the moment? So thank you for those comments.
Thank you. Shall we turn to consideration of the vote, if we can show the motion? And I believe that the general view that I'm hearing is that we insert holding the line at 3.6 as the proposal in the motion for today. In other words, that the commission hereby establishes the healthcare cost benchmark for calendar year 2026 as 3.6.
Okay. So we can take a vote to establish the benchmark for 2026 at 3.6% if we have a motion to do so.
So moved.
And a second.
Second.
I'll second.
Thanks very much. Okay, Madam Chair.
Aye.
Vice Chair Cohen,
Aye.
Commissioner Castiel,
Aye.
Commissioner Coughlin,
Aye.
Commissioner Cutler,
Aye.
Commissioner Haupt,
Aye.
Commissioner Master Giovanni,
Aye.
Commissioner Wilmoth,
Aye.
Commissioner Sullivan,
Aye.
and Undersecretary Mahania.
Aye.
Thank you.
Excellent. Thank you so much. So we'll now turn to three different areas of reporting from the team: the ACO LEAP certification, the OPP annual report, and our executive director's report. And I'll ask our executive director, David Seltz, to introduce these topics.
Great. Thank you, commissioners. We're going to switch gears a little bit here in the next two agenda items and bring you up to speed on the important work of our agency in two particular areas. One is in our ACO certification program, which has been a long-standing program at the HPC. It has a 2-year cycle period, and so we're excited to be able to provide an update to the board about some of the important changes we're making in this cycle of the certification program. And then after that agenda item, I'm excited to be able to invite our director of the Office of Patient Protection to give an update on their annual report as well. But first, we'll start with the ACO certification program, and happy to turn it over to Mike Stanek.
Great, thank you, David. And good afternoon, commissioners. I'm Mike Stanek. I'm a deputy director on the Healthcare Transformation and Innovation team. Happy to be here today with my colleague, Courtney Anderson, to provide an update on the HPC's Accountable Care Organization certification program. Courtney is the senior manager overseeing the certification program's operations. And before I turn to Courtney to kick off our discussion of proposed updates to the program for 2026 and 7, I want to provide a brief refresher on the program. As you know, one of the responsibilities that the HPC is charged with under Chapter 224 is developing multi-payer certification standards for ACOs in the Commonwealth. Our payer-agnostic requirements focus on core competencies of ACOs as key drivers of care delivery transformation. The program launched in 2017 when we issued our first 2-year certifications to 17 organizations around the Commonwealth. Subsequently, we produced a series of outputs like policy briefs and profiles of each ACO to further our aim of building knowledge and transparency about ACOs. Starting in 2021, we implemented our Learning, Equity, and Patient-Centeredness, or LEAP criteria. The LEAP criteria embrace the ACO model as a catalyst for learning and improvement among provider organizations, and they recognize the role that ACOs can play in advancing health equity in the Commonwealth. You'll hear more about the LEAP criteria from Courtney in a few minutes. Looking down the line of it, we'll be approaching the 10-year anniversary of the program at the end of 2027. Over the next 24 months, we'll be getting ready for that milestone by doing lots of reflecting on the program and the state of value-based care and planning for the future. And we look forward to engaging with you on that work. Next slide, please. I want to provide a quick snapshot of the scale of the program at present. As of right now, there are 17 certified ACOs, which collectively hold 90 commercial, mass health, and Medicare risk contracts, and cover more than 3 million lives in Massachusetts. You can see here the list of those ACOs, all of which have been certified now for multiple cycles. I did want to call out in particular 3 ACOs, Health Collaborative of the Berkshires, Neighbor Health Corporation, and UMass Memorial Health. Those 3 ACOs were all just recertified for 2 more years at the beginning of 2025. As always, we want to congratulate and thank all of these organizations for their partnership, and most importantly, the dedication that they have shown to providing high quality, efficient healthcare to their patients. Next slide, please. Before I turn to Courtney for an overview of our upcoming certification cycle this year, I want to share a few findings from our recent data points that we released on the ACO certification program. We've completed 4 two-year certification cycles since the program launched, and we now have comparable information going back to 2019 and in some cases 2017. And that allows us to see what has and has not changed in recent years. Here we have a few very high-level observations about ACO's risk contracts and care delivery transformation efforts. Overall, the number of lives in certified ACO's risk contracts has been fairly steady since 2019, growing only slightly. The share of covered lives in public payer risk contracts has been growing, reflecting overall growth in mass health enrollment and declining commercial and insurance enrollment over that period. As we've seen in the past, risk contracts tend to be more common in HMO products than in PPO products, but the prevalence of PPO risk has grown since 2019. And this is important because PPO products are such a significant portion of the commercial market. One of the most notable recent trends in risk contracts has been the addition of incentives in recent years for reducing racial and ethnic disparities on quality metrics. On the care delivery side, we've seen considerable ACO activity with respect to population health management interventions, advanced primary care models, whole person care delivery that includes integration of behavioral health, and greater use of care modalities like virtual visits. Next slide, please. In the last certification cycle, in some of our supplemental information collection, ACOs were given an opportunity to share some of their top strategies for delivering higher value care. Significant majorities of the ACOs pointed to using technology to manage care, new delivery models, and provider-level performance reporting. Other common strategies included keeping care within the ACO and investing in upstream interventions targeting the social determinants of health. Additionally, some of the major facilitators of delivering higher value care that they identified were access to payer data that provides the insights needed to monitor and coordinate care for patient populations, incorporation of social or behavioral health supports into care models, and patient engagement opportunities, for example, in care navigation and care management. Next slide, please. We also asked ACOs in which areas they found it most difficult to achieve their own performance targets. And perhaps unsurprisingly, the top 3 areas identified were quality, cost trend, and efficiency targets. Some of the primary challenges that they described in meeting those targets included workforce issues like provider turnover and recruitment challenges, patient access issues rooted in capacity constraints, patient boarding in emergency departments, limited influence over providers outside of the ACO, and challenges of collecting race, ethnicity, language, and disability data for disparities reduction. We have a lot more information on ACO's activities on the HBC website in Data Points Issue 28, so I would encourage folks to take a look at that. With that, I want to turn it over to Courtney for an overview of this year's upcoming certification cycle.
Thanks, Mike, and hello, commissioners. If we could go to the next slide, please. So today, as Mike said, I'm going to be previewing the updated standards for this upcoming certification cycle. To start, we have 3 sections of the application, starting with the prerequisites, which is the section where the applicants will attest to having the basic structural elements of an ACO. So they need to have a governing body, at least 1 risk contract, and they must be in compliance with state regulatory requirements like having an RBPO certificate and an up-to-date RPO filing. The second section of the application is the assessment criteria, which are the standards that the ACO must meet to achieve certification, and where we gather information on how ACOs are driving care delivery system transformation. So this year, the content of the sections remains the same as the previous year, though we've made some minor changes to the criteria that I'll review in the coming slides. So in the assessment criteria, we ask applicants to describe and meet standards relating to fostering a culture of continuous performance improvement, innovation, and learning, implementing population health management programs to coordinate care, manage health conditions, and improve health, using the best available evidence and data to support high-value care delivery, supporting whole person care by integrating behavioral health and health-related social needs into care delivery models, and collecting and using information from patients to improve their experience. We also have a health equity requirement where the ACOs describe how they utilize data, strategy, and patient engagement to effectively reduce healthcare inequities in their patient population. And you'll see the third section of the application is the supplemental information section, which are questions where we ask about the ACO's activities and operations to gather information that will inform future certification cycles and advance public knowledge and transparency. The applicants are required to answer these questions, but the HVC doesn't evaluate the responses submitted. Next slide, please. As I mentioned, we've made a few minor updates this year to the criteria, which we hope will clarify and streamline the requirements. We've reordered the criteria to improve the flow of the application. So we start with organizational level activities, moving into specific care delivery transformation efforts, and then we ask about the experience of the patient and direct patient care. Some specific changes to the criteria that we've made include streamlining culture of performance improvement response options based on what we've seen in previous applications. So now we're just asking for 3 response options. We're focusing the criterion on the commitment of ACO leadership to monitoring and improving performance, internal financial incentives, supporting improvement among ACO participating providers, and finally, ACO support systems or processes to encourage innovation and improvement. We've also reframed patient-centered care to improving the patient experience. So we did this really to clarify that we're expecting the ACOs to demonstrate regular monitoring of patient experience and that they are implementing efforts to improve patient experience based on what they've learned. Finally, we've also changed data-driven decision-making to high-value care. Our expectation for this criterion hasn't changed. We're still expecting that ACOs adopt processes or tools to make current clinical knowledge available to providers and that they're offering providers actionable data on their performance. But the rebranding here is to emphasize that our interest is in how ACOs are contributing to the delivery of high-value care. We're also advancing the standard set in the health equity requirement, expecting ACOs to continue their focus on reducing healthcare inequities within their patient populations. Next slide, please. So to review the details of our updated health equity requirement, so this is the 3rd cycle where we've required some form of health equity response. Our goal is to collect information on health equity activities at regular intervals with the expectation that ACOs will demonstrate increasing sophistication and progress in these areas over time. We've worked to align our expectations and our approach with those of other stakeholders in Massachusetts focused on promoting health equity, such as MassHealth, private payers like Blue Cross Blue Shield of Massachusetts, and the Quality Measure Alignment Task Force. Our requirement is one way we feel we can use ACO certification to promote this statewide effort. Focusing a little more on the details, ACOs must describe how they collect data to identify health inequities in their patient populations, and then design programming to address those inequities that they discover. This year, we're looking for ACOs to show that they're incrementally expanding the scope of their data stratification activities as they continue to build up their data collection capabilities and work to integrate equity into their quality improvement approaches. The ACOs should also be meaningfully engaging patients affected by the identified inequity to incorporate their perspectives into the design and implementation of health equity programs. We're keeping this section reporting only for now until we make data-driven health equity interventions a requirement for ACOs in future certification cycles. So we look forward to working with ACOs in this area as they continue to build this competency. And then finally, ACOs must demonstrate how they've incorporated health equity goals into strategic plans and implemented programming based on these goals. So last cycle, the ACOs were just getting started incorporating health equity into strategic goals. And so this was a reporting only activity. And this year we're setting the expectation that ACOs have changed or adopted operations to achieve their equity goals. This could be demonstrated in a variety of ways, such as making available dedicated staffing, funding, or technology for equity efforts. Next slide, please. So this year, we have 3 supplemental information topics. So as a reminder, for this section, we don't set standards, but ACOs are required to answer the questions. And we use this data to advance our understanding of ACO priorities and activities, which may inform future certification criteria, as well as promoting public knowledge and transparency about ACO operations. Our first SI question focuses on the degree to which ACOs are incorporating health equity elements into the activities and approaches described in their responses to the 5 core assessment criteria. The next 2 questions were SI topics in certification year 2019. We're asking about them again because the content is still relevant and it can help give us a longitudinal perspective to see what has changed. We're asking about high value care, how ACOs are implementing strategies to address unnecessary utilization in areas of low value care, such as screenings that are not clinically indicated. Finally, we're asking about distribution of shared savings and performance-based compensation. So we'll ask ACOs to describe their approaches for developing distribution methods for shared savings and losses under risk contracts, as well as estimates of the percentage of total provider compensation that is performance-based. Next slide, please. So a quick overview for our plans for the remainder of 2025. In the coming weeks, we'll be planning to release the application requirement and platform user guide, which we call the PUG. And we'll be updating the online application platform in the coming months to reflect this year's changes to the criteria. This summer, we'll be holding a webinar for ACOs applying for certification this year to review the new standards. And we're also planning to host a webinar for the certified ACOs exclusively, where ACOs and national experts will discuss strategies for addressing healthcare inequities. We'll also be providing regular support to ACOs preparing their applications, including hosting office hours and responding to ad hoc questions. This fall is when the application will kick off. The application portal opens around September 1st, and applications are due October 1st. We'll be sure to notify the ACOs of their certification status by the end of the calendar year, and new certifications are effective January 1st, 2026. So that's it from us. Thank you for your time, commissioners. Happy to answer any questions you may have.
Thank you so much, Courtney. Can we move the screen to show all commissioners, please? Thanks. Want to just start us off by saying I'm really interested in those supplemental information topics. Are the ACOs aware of what those are yet? And if so, have they had any feedback on them?
No, this is the first time we're announcing publicly what the SI questions will be, and we will be discussing it with them when we preview the criteria this year.
Great. Yeah, they seem really useful, so I'll be interested to see what the ACOs think of them. Any questions or other thoughts or comments for Courtney? Great, thank you so much. Really good to think about the outlook on this. We'll now move to our next topic, which is around the Office of Patient Protection Annual Report, and David Seltz will introduce our next presenter, Nancy Ryan.
Thank you, Madam Chair, and great presentation, Mike and Courtney. Switching now to our Office of Patient Protection. This office serves an absolutely critical role in ensuring that patients and consumers' rights are protected here in Massachusetts. This office is the most direct liaison that we have with the public in terms of being able to help them navigate a very complex healthcare system and their associated rights to get the care that they need and deserve. So always thrilled to have this annual opportunity to check in with OPP, and we'll turn it over to our director, Nancy Ryan.
Thank you so much, David. Good afternoon, commissioners. So as David said, I'm here to present the findings from the 2023 Office of Patient Protection's annual report detailing our work assisting consumers with healthcare access issues. As a reminder, and also, I know we have a couple newer commissioners on the call, so just wanted to go over OPP's 4 primary services offered to consumers. The first is allowing for the opportunity to purchase health insurance for those consumers who missed the open enrollment period through an open enrollment waiver. Regulating and administering health insurance appeals for consumers who have been denied coverage by their health insurance company. Also regulating and administering appeals for patients of accountable care organizations and risk-bearing provider organizations who've been denied a referral or other service by their provider. And then also operating a hotline and answering all sorts of questions, as well as online inquiries addressing a wide number of patient concerns. And before we get into the report, I just wanted to take this opportunity to thank the OPP staff that are completing this work every day: Stephanie Carter, Eric Rollins, and Liza Garcia. The OPP 2023 annual report details OPP's work in that year. And if we move on to the next slide, I'll just present a few snapshots here. So this slide details OPP's first consumer service, which is issuing waivers for those consumers who would like to enroll in commercial health insurance and who unintentionally missed the open enrollment period. The open enrollment period usually runs from November through January each year. So this is a service that we offer during those other times of the year. This year, OPP saw a decrease in waivers compared to 2022. This is really due to the end of the federal public health emergency in 2023 and the related reinstatement of mass health renewals, as well as the end of COBRA-related federal protections. So due to the end of those initiatives, the Division of Insurance and the Health Connector created a special open enrollment period from April through November 2023. So it's just in that year, 2023, people needed fewer waivers. So therefore we issued fewer we had fewer waiver requests come in through us. As you can see from this slide, as usual, OPP approved the majority of waiver requests we did receive. We deny waivers when there's missing information on the request, the person already has insurance, or the person had the opportunity to purchase health insurance during the open enrollment period, but did not. And for this service in particular, OPP works really closely with the connector to assist consumers enrolling in health insurance and just to troubleshoot complicated situations that consumers face. If you go on to the next slide, the following few slides really detail the health insurance appeals process, which is the second service that we offer. So we regulate the internal appeals process, and insurance companies reported to OPP that they received over 15,000 internal appeals from members in 2023. This number is higher than previous years, and it represents all appeals received by the health plans, not just those related to medical necessity. And as you can see on the slide, 48% of consumers who submitted an internal appeal to their health insurance company received coverage as a result of that appeal. If you can go on to the next slide. This is a snapshot of the OPP process where we facilitate external reviews. So for those consumers who were denied at the internal appeal administered by their health plan, 303 requested an external review from the Office of Patient Protection. The external review is the second level of appeal that allows the consumers to have their case examined by an independent healthcare professional contracted with OPP. Consumers were granted the requested coverage in 44% of the cases. And OPP saw a slight increase in the amount of cases that we received in 2023. So, we keep, as you'll see it towards the end when I show some 2024 numbers, we keep sort of increasing the amount of appeals that that we received from consumers wishing to get an external review. So, I think that's a good thing as we move forward. If we go to the next slide, the annual report, which will be released today, goes into quite a bit of detail into the types of reviews that OPP processes as well as their outcomes. This is just a quick snapshot that shows the medical surgical eligible requests broken down by type of service. OPP received 61 eligible requests for outpatient medical surgical services. 23 were resolved in favor of the patient. This is admittedly a little bit of a catch-all category, but primarily represents surgeries, medical visits, and outpatient rehabilitation therapies. OPP is examining this category to see if there's any services we could sort of pull out of outpatient services so we can report sort of more specifically on the types of services that fall within what we call outpatient services. Pharmacy is typically the highest category for us. In 2023, it was, the second highest category. There were 36 eligible requests for pharmacy medications. 16 were overturned by the external review agencies and 1 was resolved prior to a decision, meaning that 47% were resolved in favor of the insured. There's a large number of medications requested and sort of diseases being treated in this category. As you would expect, these are, requests by and large for newer, more expensive medications to treat chronic conditions. Diagnostic services was sort of on par with pharmacy. We received 35 requests for diagnostic services. 22 of those 35 requests were for cancer screenings. And many of those were considered experimental investigational by the health plan, which is a slightly separate process where there are actually 3 reviewers rather than 1 reviewing the medical necessity of that diagnostic screening. And 12 of the 35 requests for diagnostic services resulted in a favorable outcome for the patient. This slide does not include behavioral health requests, although the report does detail the behavioral health requests received by OPP. In 2023, OPP received 21 eligible behavioral health requests. This represents a slight increase from 2022, breaking the trend where we've seen a decrease every year, but still sort of just really a slight increase. We do not see a huge number of behavioral health requests come through OPP. If you go into the next slide, we transition to the third service, which is the regulating internal appeals and processing external reviews for patients of risk-bearing provider organizations and accountable care organizations. This is a process where patients can challenge decisions by their provider organization related to usually referrals, but also type or intensity of services, timeliness of services, or other concerns related to the RBPO and ACO's financial incentives. The first level of the appeal, similar to the health plan side, is internal to the provider organization, just like I said, just as in the health insurance context. So you can see the majority of internal appeals were upheld by the RBPO or ACO. In terms of types of appeals, as noted on this slide, 76% in 2023 were related to referral restrictions and 21% related to the type or intensity of service. The next slide gives some sort of general background on OPP's external review process for RBPO ACO patients. During 2023, OPP received 6 requests for external review from patients of RBPOs and ACOs. It's, very few, continues to be very few. Of those 6, all were eligible for external review. 5 out of 6 concerned referral restrictions. In half of the cases, the external reviewer upheld the denial of the RBPO or ACO, deciding that the requested referral was not likely to produce a more clinically beneficial outcome for the patient. And 3 cases were overturned by the external review agency. This 50-50 split, although it's really small numbers, it does represent a change from previous years where, previously the overwhelming majority of cases resulted in the provider organization's denial being upheld. If you go into the next slide. This is our last, but definitely broadest service. We assisted over 1,500 consumers just via our hotline in 2023. This doesn't include like all the emails and online inquiries that we also lodge. This is sort of a decrease on the hotline, at least from previous years. This is just generally because fewer people are calling for information about open enrollment waivers. As I mentioned before, there's more opportunity for people to enroll directly without the need for an open enrollment waiver in 2023. So that's, you know, they sort of go hand in hand, that volume. And, you know, just noting, of course, we can't assist, you know, a consumer with every single thing that they need. So we make every effort to provide a referral and provide information and resources to every consumer that comes through to us. I've included a quote, as usual, from a consumer who OPP assisted. This person is just one of the many people with whom OPP interacts with every day, whether that's over the phone, by email, where we try to really understand what people are going through and assist them to the extent possible. On the next slide, I just give a little bit of an update since 2023. And like I said before, in 2024, we saw an increase in the amount of health insurance external reviews received, over 350. We saw slightly fewer waivers in 2024 and a relatedly slight dip to our hotline. This month, OPP released sub-regulatory guidance to all fully insured health plans that clarified requirements for the staff who serve as internal reviewers deciding the internal appeals at health plans. And the guidance also clarified requirements around plan communication to patients after a patient receives an overturn as part of the OPP external review process. So just sort of getting, shoring up that communication to make sure that implementation of OPP decisions is smooth and, you know, really can happen without delay, which is what is required under the regulation. And just noting here, we continue to collaborate with other state agencies on issues impacting OPP and the consumers we serve. So that's really a constant every year and every day in OPP. And I'm happy to answer any questions that the board may have.
Thank you, Director Ryan. My gosh, what a lot of very high impact work. Thank you. Any questions from commissioners? Commissioner Haupt?
Nancy, this is such great work that you do there and such a wonderful resource for consumers. My question had to do with, do you track the carriers? Do you track the number of complaints or appeals per carrier? And do you see any trends in that area where there's one that might, not naming names, but is there one that sticks out, or are they fairly across the board? Or, you know, if you do see one that sticks out, how do you handle that? I'm just really curious what you're seeing from that end.
Yeah, we definitely track external review requests by carrier, and the carriers report on their internal appeals every year in April. So we have that information, and we report on both of those numbers, both the internal appeals by carrier and also the external reviews by carrier as well in the OPP annual report. I wouldn't say there's any particular trend there. It varies from year to year in terms of how many internal appeals or how many external reviews, you know, each carrier gets, and we do report it sort of in relation to the member enrollment,
right,
so that it's comparable in that way. But I wouldn't say there's any particular trend or any particular carrier that kind of stands out. You know, when we do see, I would say, like, you know, really minute trends related to a particular service or a particular type of denial, you know, we are in close contact with the Division of Insurance, and we're able to sort of, you know, work on those matters either with the carrier directly or with the Division of Insurance. So I wouldn't say there's like broad trends from those numbers that we report on, but if we see sort of more like micro trends, I guess you could say, then we definitely work on that.
Great. Thank you.
I love seeing the quote from the patient. It made me think about a question, which is, do we have other ways of getting feedback from both the health plans and the patients about our program and any constructive input about what we can do to either be more effective or, is there, talk a little bit about any feedback that we.
Sure.
See.
Yeah, I mean, we don't have a direct request, I guess you could say, for feedback from either the plans or from consumers. We always get the quotes from consumers for people who just like spontaneously decide to thank us, which is always nice.
Yeah.
And the plans, I would say, we have a close working relationship with them. So they give us feedback, through our working relationship with them, but we don't have like a feedback loop standardized in any way, like on the forum to say, how are we doing, or to plans or vice versa. That's something, we could certainly think about.
Yeah, but in the working relationship, we're getting feedback and responding to that. Thank you.
Yeah, and I'll just point out, for example, the bulletin that Nancy mentioned regarding the facilitating the implementation of decisions. We developed that very much in collaboration with the health plans. So I think you're absolutely right, Chair DeVoe, about it's sort of the ongoing kind of collaboration, which is by necessity we have to do. So it's a close working relationship.
Great. Commissioner Coughlin?
So I just had like in a general opinion, like when you talked, Nancy, about like the differentiation between like plans, if we're seeing more like a trend more with some plans as opposed to others. If you are seeing anything between, because we read about it so much about Medicare Advantage programs, plans versus straight Medicare. Like, so our older consumers, are you seeing a difference between denial of benefits or requests for appeal related to Medicare Advantage, programs?
Yeah, so OPP's both regulatory authority and our external review process is only for fully insured Massachusetts health plans. So it doesn't include either Medicare Advantage or traditional Medicare plans. Of course, we do, sometimes hear complaints or, people call us about those issues, and we really just direct those out. So I don't think we would, unless it was something that was very striking coming in on our hotline, I don't think that's a trend that we would necessarily see because people are usually directed elsewhere.
Okay.
Great. Is there other questions or comments? If not, thank you so much, Director Ryan. This is such an important part of our work and really appreciate the report.
Thank you.
We will now turn to our Executive Director's report.
Thank you, Chair DeVoe, and thank you, Director Ryan. As you heard, this is a really important public resource that the Health Policy Commission provides, and is something that we've had since the very beginning of our establishment, all the way back in 2012 and 2013, as this office moved from the Department of Public Health into the Health Policy Commission's umbrella. And as Nancy shared, it is a small but mighty team of really dedicated professionals that work every day to help consumers, sometimes in crisis, in very complex healthcare decisions. So thank you for your work. In my executive director's report, we'll be providing some updates, but before I begin my part, I'm going to turn it right over to Kate Mills for our market oversight update at each meeting. Go ahead, Kate.
Great. Thank you, David, and good afternoon, commissioners. Here I have our standard slide summarizing all of the material and change notices we've received to date by type. In total, we've now received notice of 186 different provider transactions. And of these transactions involving physician group mergers, acquisitions, or contracting network affiliations continue to remain the most frequent, followed by the formation of new contracting entities. On the next slide, you'll see that now that the CMIR has officially concluded, we have 3 material change notices under review. First, the proposed acquisition of Vibra Hospital of Western Massachusetts, which includes an inpatient long-term acute care hospital and a skilled nursing facility by Everest Hospital LLC, which is a newly formed Massachusetts corporation in coordination with Milk Equities LLC, which is a private investment vehicle with ownership interests in other nursing facilities. Second, we have a proposal by UMass Memorial Healthcare to merge Marlborough Hospital. Oh, was there a question? Oh, I will continue. We have a proposal by UMass Memorial Healthcare to merge Marlborough Hospital, which is already a UMass Memorial Community Hospital, to merge that into the UMass Memorial Medical Center license. So that would make Marlborough a licensed campus of the UMass Academic Medical Center. And finally, we have the proposed acquisition of the oncology testing business of BioReference Health LLC, which operates 10 laboratory facilities nationwide by Laboratory Corporation of America Holdings, Inc., which is a multinational laboratory services provider. All of these are under review currently, and we will be in touch as we develop findings on each. And on the next slide, we wanted to provide you an update on the material change notice process itself. So as you know, Chapter 343 of the Acts of 2024, the market oversight legislation that passed at the end of last session, included a number of changes to our market oversight authority, which we discussed at both our January and February board meetings this year. Those changes went into effect as they relate to the material change notice process on April 8th. So some of the types of things that are now changes to that process, for example, is that there are 4 new categories of transactions that now have to be noticed to the HPC, including significant expansion in a provider's capacity, transactions involving a significant equity investor that result in a change of ownership or control, significant acquisition, sales, or transfers of assets, including real estate leasebacks, and conversions of a provider from a nonprofit to a for-profit entity. The legislation also expanded the HPC's authority to collect information from significant equity investors and other parties to transactions. As we previewed at our February 27th meeting, we will be going through the full regulatory development process to update our regulations through the remainder of this year. However, recognizing that these provisions are in effect as of April 8th, we issued guidance directing market participants on how to comply in advance of the fully updated regulations. And that guidance, along with an updated material change notice form, is issued and available on our website. And I just want to emphasize that, as always, we really urge any market participants who have questions to reach out to us. We're always happy to talk through the details of any given material change notice with folks. And we look forward to engaging with you, our commissioners, and our market participants over the remainder of the year as we update our regulation. And I will pause there for any questions before I turn it back to David.
Seeing none, I'll keep us moving. On the next slide, I am thrilled to be able to announce that we earlier this month launched, in partnership with the Department of Public Health, a new maternal health access and birthing patient safety task force. This task force was established in law through omnibus maternal health legislation that was passed by the legislature and signed by the governor last year. And this new task force is really focused on assessing maternal health access across the Commonwealth for all populations and communities, and making policy recommendations to ensure that these services are aligned with patient need. We're thrilled to be able to begin this work, as I said, in partnership with DPH, but also with a number of other named members from other state agencies, provider groups, quality improvement networks, and a birth center. As you can see here on this slide, the task force is being co-chaired by Dr. Christina Alonso Lord, who is the designee of Commissioner Goldstein from the Department of Public Health. And in statute, the other co-chair is the executive director of the Health Policy Commission or their designee. And in this case, I was thrilled to designate and for her to accept the appointment of to be the HPC's co-chair is Dr. Alicia McGregor. Her expertise in maternal health services is well regarded and known, and she has done really groundbreaking work in thinking about disparities in access and the impact of closures in maternity care and how that can impact patient care as well. So one of the duties of this task force is going to be looking at past closures of hospital maternity units or birth centers, evaluating what may have led to those closures, what the impact of those closures was on patient access to care. And as I said earlier, really making policy recommendations for improving maternal health care across the Commonwealth. There's a number of very specific deliverables for the task force. And the last thing I'll just say on this is that as you've heard me just now talk about the need to assess capacity, to plan for the future, to ensure that access and capacity is aligned with patient need. Many of these same types of questions are the questions that our new Office of Health Resource Planning is going to be tackling as we think about a broader range of services and how they align with patient need and distribution. So as part of supporting the work of this task force, members of that new Office of Health Resource Planning are going to be conducting some of the necessary research and work to help effectuate the goals of this task force, really as almost a pilot for our Office of Resource Planning to be able to test new ways of methodological assessment and what we might do. So a great opportunity to contribute to this task force while also building up our internal capacity on health planning. Next slide. The work of that task force aligns quite nicely with the timing of today, which is the last day of Black Maternal Health Week. And we wanted to recognize this important week. This has been an area of top priority for the HPC, recognizing that the rates of severe maternal morbidity are much higher for Black birthing people than for other populations. And we have implemented, as you know, throughout the years, both targeted investment programs to reduce disparities, as well as dedication to research that can help us understand some of the root causes. On the next slide, also thrilled to announce that just yesterday, we launched a new primary care access delivery and payment task force as established in the new market oversight law that was passed earlier this year. This is a 25-member task force that includes myself and Dr. Kiami Mahanya from EOHHS as the co-chairs. The work of this task force is critically important as we think about what will be needed to strengthen and stabilize our primary care delivery foundation as well as our workforce. It has a number of very ambitious charges ahead of it. And we kicked off this task force yesterday with all of the members, and there was an incredible sense of commitment to the work of the task force, urgency to tackle the problem that was in front of us, and a resolution that this task force not merely provide policy recommendations that kick the can down the road, but really drive towards consensus and actionable steps to improve primary care this year. I'll pause here. Dr. Mahanya, I don't know if you wanted to add any other very brief reflections from yesterday's kickoff task force meeting.
No, I would say that, like David, I really share the excitement. Obviously, when you bring that many stakeholders into one place, there's going to be some clashes and some disagreement. But I think overall, there was already a sense that we were all agreeing to move in a certain direction. And everybody realizes the status quo has to go. So, And of course, you all know this, but the HPC staff has done most of the work in terms of organizing and lifting this, and it's really been amazing to work with them.
Thank you. In both of these task forces, we see a real opportunity to contribute to an important dialogue and have committed the staff and resources necessary to help make these a success. And doing so in partnership with EOHHS has been really great. This is a top priority for all of you commissioners. Earlier this year, we released our dire diagnosis report on the state of primary care. And I plan to provide an update to you at each of these board meetings on the activities of both of these important task forces as this moves forward throughout the year. And that concludes my executive director's report. There is a public meeting calendar shown here, but thank you for your engagement on all of these topics today, and I will turn it over to Chair DeVoe to close out our meeting with a final agenda item.
Thank you so much, David. And thanks for that slide. And then if we can convert the screen to show all commissioners for the discussion. Thank you. And thanks all for bearing with me as my technology, I'm not able to show both you and the screen at the same time. So I really appreciate the staff helping me toggle back and forth. So I now have the pleasure of introducing our last agenda item, which is our executive director contract renewal. And let me start by, both for new commissioners and also to just refresh the memory of our continuing commissioners, let me start by just describing how we do this. So we have a contract with our executive director that has a 3-year term. And so at each of those 3-year terms, it's my responsibility to propose a contract renewal, also to solicit the interest of our executive director in being in continuing, and then to propose a contract renewal approach. And we do that first at the Administration and Finance Committee. Our members for that are Commissioner Cohen, Commissioner Sullivan, Commissioner Mastrogiovanni, Commissioner Houp, and myself, and have a discussion and input from each of the commissioners on that committee about the proposal. And then we bring that proposal forward to the full board today with the request to authorize me to then move ahead to negotiate a new contract with David Sells. So the purpose of today's meeting is for me to describe, where we are, what I'm recommending, have a discussion, and then like to bring it to a vote, which would authorize me to take the next step to sit down with David and talk this through. And he has indicated his interest in continuing as our executive director. So I really thank the members of the Administration and Finance Committee for a very robust discussion, which we had Friday the 11th. I was just looking at the date here. There are really 3 key components to our executive director contract. One is the term of the contract. The second is the base salary for our director. The third is inflationary increases and how to handle that. And the feedback from my fellow commissioners on that committee was first around the importance of considering both the performance and the longevity of our executive director, which really are both exceptional. I do an annual performance review with each commissioner and also with external entities and with members of the team at the HPC around 3 levels of performance. First, feedback about the HPC in general. Secondly, feedback about my own performance and what we could change or do better. And the third, feedback about David Sells. And the first time I did this contract review, which is now 2.5, 3 years ago, I was new to the commission. And I really was just absolutely floored by the fact that I never hear anything but stellar response to the HPC's executive director and the entire team that he has built. And I routinely get feedback like, do you realize that you have the best team, et cetera. So, and I can tell you that this past cycle was no exception to that. So members of the NF committee wanted to make sure that we're, fully weighting both the performance and the longevity of our executive director who's built the agency and continues to evolve it, particularly as we've been given the new responsibilities that significantly expand our work and require recruitment of some new leaders to the organization right now. So our new responsibilities have just gone into effect, and it's required posting both leadership positions and also staff positions, and having the benefit of an executive director, because obviously this is a major factor that people consider in staying with the agency or coming to the agency. The feedback of our other commissioners was that these are all important considerations as we look at this next contract. And as one commissioner commented, we need to really think about our executive director role as a new job. It's expanded and changed significantly with the legislation and over the last 3 years. The other feedback that I got from the committee was, in addition to the discussions I've had with commissioners about the performance review, is this has really been a very exceptional past year and a half in terms of performance around 3 areas that are critically important to the HPC. One is the support that the HPC provided to the frontline regulators on the steward crisis. And both Secretary Walsh and others have commented on how critical the support of the HPC team in producing information, and also on having that ability to talk with our executive director about how to move forward, how critical that was to the moving through on that crisis. Secondly, as we know, the board has felt for several years that the changes in legislation that would give us different responsibilities and authority were critical to our ability to perform our core functions. And that legislation, the HPC team, obviously led by David, was very important in working through successful passage of that legislation and the areas of focus in the legislation. And third, the completion of the agency's first PIP, which was both important in terms of working with MGB and their completion of a successful PIP, but also as a model, given that it's our first model for future work, and a lot of learning and very important navigation there. So I think this has been really important, 18 months, and the outlook on the role significantly changing. So with that, the recommendation that I wanted to bring forward was first on the term, proposing another 3-year term for the contract. It would be effective 1/1/26. And then on the base, we look at the most recent information around comparable positions in government and in the other independent agencies, where it's a very transparent and current set of facts. So it's very useful in establishing the base, and I would ask the board, as you vote for me to move forward and authorize me to negotiate, that I will set the base at the appropriate level given those comparable positions, and then an inflationary increase. And our inflationary increase for our executive director has been 2.5 each year for this last cycle. And there was discussion at the A&F committee meeting that given the kinds of increases that have occurred for the government agencies in the past and what's happening in the market, that there was justification for considering a higher inflationary increase. But then also was brought out by another member of the committee that given the financial pressures that state government is under and the difficulty of predicting what might happen with inflationary increases for other government employees over the 3-year term of the proposed agreement. After a robust discussion, I think where I'm landing is that I feel we should stay at the 2.5% of inflationary increase. And we do have the option of deciding to do a one-time payment in any year that performance or inflation warrants it. So we can, keep a careful eye on what's happening with inflationary increases that are comparable within government and also on performance, and decide to do that. So let me stop there in terms of the my presentation, but any questions or any other comments from the A&F committee members? Have I missed anything in reflecting the discussion there? Commissioner Haupt?
Yeah, I just wanted to say, in addition to the increased responsibilities because of the legislation, we have a significant change in the board composition itself, and that is something that takes quite a bit of time and adjustment and education. And so I think the combination of those two things, the change in the board and the increased responsibilities, sort of led us to talk about this being a very different job going forward.
Exactly. Thank you. Really good point. Yeah, we do anticipate, because of the change in the requirements for commissioners, that we will have some significant changes come July 1st, and it is important to have the onboarding briefing and partnership and management of our executive director in that. Thank you for bringing that up. Other comments or any questions either about the process for how we do this or about the specific recommendation? If not, then can we move to the vote?
We absolutely can. So I will ask for a motion for the chair to handle the executive director's contract renewal process.
So moved.
And a second?
Second.
Okay, starting with you, Madam Chair.
Aye.
Vice Chair Cohen?
Aye.
Commissioner Castiel?
Aye.
Commissioner Coughlin? Commissioner Cutler?
Aye.
Commissioner Haupt?
Aye.
Commissioner Master Giovanni?
Aye.
Commissioner Wilmoth?
Aye.
Commissioner Sullivan?
Aye.
And Undersecretary Mahania.
Aye.
Great, thanks very much.
Thank you so much. And I really want to thank everybody for the really productive, important meeting today. And before we close out, I just wanted to mention that the next HPC board meeting will be held at the HPC office. So we are actually asking commissioners to attend in person on Thursday, June 5th at 12 p.m. And if you're not able to attend in person, if you could let us know right away, because we do want to have this opportunity to also thank outgoing commissioners in person on June 5th. So with that, any other final comments or questions before we close? I don't think I see anyone. So with that, thank you all, and we will adjourn.
Thanks, Deb.
Thank you.
Thank you.
Thank you.